Yeah, so I've titled this talk Feeling Restricted, because we're going to focus on restrictive lung diseases. But you'll see the approach is actually patient specific, and we'll go through those points. So basic strokes, lung disease is either ventilatory or perfusory, meaning that there's problems with getting air into the lungs or problems with getting blood into the lungs. And then on the ventilatory side, obstructive or restrictive processes. It's kind of a pathophysiologically broad strokes approach to understanding what's going wrong in the lung, and something that we can use to think about our process of managing these patients. Back to basics, just to quickly talk about some physiology. If you look at the red numbers, effectively ranges on the left-hand side, those are volumes that are standard in the lung, whereas the capacities on the right, those are kind of one minus another one, or one plus another one of the volumes. And it just gives us an idea of what the lung function is about. So VT, tidal volume, normal breath in and out from inspiration to expiration, that's the volume. Above that's your inspiratory reserve volume, and below that your expiratory reserve volume, with a residual volume at the bottom. So if you breathe your lungs all the way out, you can't breathe any further out. The air that's left in the lungs, basically keeping them open, is the residual volume. And that differs from your functional residual capacity in that it's the difference between complete empty lungs and a normal expiratory breath. And the inspiratory capacity is from the other side. So from the bottom of your breathing cycle up to the maximal fullness of your lungs. A total lung capacity is then those two added, and a vital capacity is from full expiration to full inspiration. And it's just important to think about what's going wrong in each set of lungs that you're dealing with. Each patient has their own concerns, and it's just important to think about that. And another important concept is then how these are dynamically changing. So if you look at flow volume loops like we do in MOPD, then you can see how obstructive pictures and restrictive pictures differ. So effectively, your restrictive picture pushes the graph to the right. So there's smaller lung volumes, but they decrease proportionally. So then you get an FEV1 over FVC of more than 0.7, even though that they're both smaller than they would otherwise have been. And that differs from obstructive, where we look at the FEV1 over FVC less than 0.7. And that's helpful in making the diagnosis and giving us an understanding of what pathophysiology may be at play here. I think it's important to understand that this is of limited use in ICU setting in general, unless you've got a patient who's known with these diseases prior to being in ICU. And then you can have an understanding of where they might be. We won't be able to do this kind of investigation on an ICU patient, and for that matter, something that we treat regularly like ARDS often leans towards the restrictive side of things, even in a patient with an obstructive picture.
So we don't often, we don't often look, if you look at your patterns, we don't always look at those flow volume curves, because they're on the next screen of the ventilator. We have the other ones, but the flow volume loop is on the patient. It's on the next side of the ventilator, on the ventilator stuff. Yeah, I must show you what it looks like. I mean, it is that question that you've got about, is this patient now, has he got bronchospasm, yes or no? But then if it's a sick lung, are they more restrictive rather than, and that helps you a little bit with the flow volume.
Yeah. So just for the guys who've arrived, just kind of quickly just covered some basic physiology, talking about lung functions, the capacities and the volumes, which I think we all know, and then just gone on to kind of obstructive versus restrictive patterns, and just how the physiology of that works, but it's not really the big focus of today.
Sorry, Johnathan, to interrupt, but I think the problem is just on the ventilator, you can't get that FEV1, because that's a force, but, so that breath is a difficult one to figure out. So it kind of helps you to know what an obstructive pattern looks like. But the restrictive is a little bit more difficult to figure out, because you don't have the FEV1 to make that calculation. Now, if you remember, so when you do your flow, your lung function, obviously the patient goes in, and does they force as much as they can and then breathe in again.
Yeah.
So that you can't do anything.
Compliance or your resistance factors on the ventilator that it does give you, because obstructive lung diseases usually have a higher compliance, whereas restrictive lung disease have a higher resistance, and that comes out in the side effects of positive pressure ventilation that we'll go through just now. Okay, so just looking at restrictive lung disease, something I think the guys in EC and surgery will be quite competent and really used to managing are the extrinsic causes of restrictive lung disease. So things that aren't necessarily the lungs themselves, so it can be the pleura or pleural cavity, effusions, pneumos or hemos, pleural thickening from previous empyema or TB, but you would see if you try and ventilate a patient with massive pneumothorax, it'll effectively, that lung will behave as if it's got a restrictive condition. Then neuromuscular conditions, so affecting the ability of the patient to breathe. And if you think about neuromuscular in the full sense of it, from central causes, so like sedation, if you give someone too much morphine or midazolam, they won't breathe. Thinking about upper motor neuron causes, ALS, those sort of things, stroke, raising intracranial pressure, brainstem conditions. If you think about anterior horn cell conditions, you can think about lower motor neuron conditions. You can think about neuromuscular junction. So lower motor neuron, the big one is GBS. The neuromuscular junction, myasthenia, and then the muscle itself could be myopathies or dermatomyositis. Those sort of things could all affect the ability of your patient to breathe and use their muscular system to create that negative intrathoracic pressure and thus breathe. And that'll also behave in a restrictive pattern. And then chest wall problems, so patients with scoliosis or obesity or pregnancy, ankylosing spondylitis, they just don't have the ability to increase their lung volumes as much as they should. Even patients like scleroderma, even if they've got limited scleroderma without ILD, might have problems with increasing their lung volumes. And then the intrinsic causes, which are focusing on the lung parenchyma, which basically means bronchioles, alveoli, and capillaries. And there's a new move away from calling these things interstitial lung diseases, because it's not technically just the interstitium that is involved. So we're calling them diffuse parenchymal lung diseases now. And those are, diffuse, we'll go through a few just slides just now just to say what they are and what we look for. But yeah, different, like the intrinsic causes are there as well. So this is our approach to diffuse parenchymal lung diseases. I'm not going to go into it too depth, but you can see, sorry, to go back, we can see that we just divide them up by known cause and unknown cause, and then granulomatous and non-granulomatous conditions. Known granulomatous are like hypersensitivity pneumonitis, amyloid, and TGBM diseases. And then if they're non-granulomatous, you're thinking about occupational or non-organic exposures. The difference between the hypersensitivity pneumonitis and the exposures are that they're organic versus non-organic compounds. Drugs like methotrexate, amiodarone, nitrofurantoin, chemotherapy, and then connective tissue diseases, which we see a lot of. And the AS there is ankylosing spondylitis. And then sarcoid and the vasculitides can cause these things as well. And then the kind of idiopathic side of things, where you get these chronic fibrosing ones, acute or subacute fibrosing, and then smoking-related ones. Important to understand that interstitial lung diseases are a clinical condition, and then there's an associated pattern that one can see on either histological biopsy or on high-resolution CT scan. And lots of these conditions can cause lots of these patterns, and there's some overlap, and it's very complicated. So like something that's like a COP can cause a UIP or an NSIP pattern, and that may be found in a certain distribution within the lungs. And that could be as a result of an infection or as a result of an autoimmune disease. So it's a little bit complex, but not really important for us to cover now. This patient comes in to EC, for example. I think we all well understand the initial evaluation of these patients. ABCs according to ACLS principles, including IV access. I think important for these cases is to get monitoring of your oxygenation and do an ABG, which will set us up nicely. Bedside therapies, consider oxygen therapy. And I say here carefully, we'll go over why just now, but often we get patients who are like quite often in EC and, that's coming short of breath, and someone pumps the oxygen up to 15 liters per minute on a polymask, and you get back to that patient 45 minutes later to see them, and they've actually deteriorated as a result. So just think about that initially. And then nebulization if needed, because some of there's not such a clear cut initially between obstruction and restriction and how you're going to manage these things. And I think we need to keep broad minds in the initial phase.
Can I just mention just about AVGs? We almost never do AVGs in EC, which I completely understand if you want to do it. So it's just, there's good evidence, the data that you get from an AVG versus VVG is not particularly different. So we work on SATs, not on the AO2. When we titrate, so we start and they're always on oxygen for a start also. So it makes it difficult to know how much oxygen they're having. So you can't work at a PF ratio anyway. So that's a bit of a difficult one. And then actually the CO2 is not that much different from venous versus arterial. And the things doing repeated ones, you have to stick with the one or the other one. So then rather stick with the venous one versus doing the repeated arterial ones. But I think it's a different story when someone's intubated.
Yeah.
Then I think there's more data, but I think we mainly will not do arterial blood gases because you get all the data really from someone's acidotic, whether it's arterial or venous, you're going to see that. If they're acidotic with high CO2, then you're going to think of putting pressure on BiPAP, isn't it?
Sure. Yeah, and then ventilatory support if needed. And we'll go through some indications and stuff for that just now. I'm sorry, backwards. Other investigations that we can consider, so guided again by your history and examination. It's important, especially in our current economic climate. But a chest X-ray for these patients is usually useful, especially if you've got concern of a new infection or kind of acute deterioration. I think that's most often very acceptable. A urine tox screen may be indicated in some patients, especially people who look as though they're a little bit drowsy and not really stimulating themselves very well, even if they've got like Cheyne-Stokes pattern of breathing. That sort of thing might try just to do urine tox screen, see if there's any opioids on board as well. And that ties in with the last point there, that I think this is coming from American data where opioid overdose is so prevalent that they often say trial of naloxone or flumazenol for benzos could be almost a diagnostic procedure to see if this patient improves or not, considering that they just may not have a good drive to breathe. I think as deemed necessary, you can do an FBC, a urea creatinine, and an HRV. And then depending on what you find clinically, I mean, if the person's got a proximal muscle weakness with a heliotrope rash, then you're thinking about dermatomyositis or hypothyroidism, do those investigations. If you've got areflexia and rising or moving weakness up the legs, then an LP for looking at your protein, looking at your cells for that albuminocytologic deficit in GBS is important. A CT brain may be important if you've got focal neurology, a high-res CT chest. If the patient is stable, those sort of things might be useful in thinking about your diagnosis. And then in our context, sputum, MCNS, and gene expert is always very important as well. So going through types of respiratory failure, I just put a little front screen of the useful approach to the ABGs and VBGs on the side. But we get two major types of respiratory failure. There's actually four documented from the study that originally did label these two, but the third and fourth are not that useful to us. So first is hypoxic respiratory failure, and that's if you got a PaO2 of less than 8 kilopascals. And then hypercapnic respiratory failure, if your PaCO2 is more than 6.7 kilopascals. And patients who have hypercapnic respiratory failure may also have hypoxic respiratory failure, which is important to understand. And then thinking about these patients who often come in, we've got a lot of people who are frequent flyers, who've got COPD, who've got interstitial lung disease, and are really chronically retaining CO2. So just try and understand that if you're expecting this patient to have a baseline high PaCO2, don't try and drive past that to a normal goal. You might compromise this patient care. And then just understand that restrictive lung diseases can cause both hypoxic and hypercapnic respiratory failure. Hypoxic primarily because of if you look at the pathophysiology, what you're actually doing is the inflammation, activation of fibroblasts, deposition of glycosaminoglycans in that interstitium causes increase in the size of that interstitial space, and the oxygen has a longer distance to traverse between the alveolus and the capillary, and thus you get poor diffusion of your gases across that membrane. And carbon dioxide diffuses really faster than oxygen. So you can get carbon dioxide across that membrane better than you can oxygen. And that's why we'll do something like a DLCO if you're at Grooteskiel. It's a diffusion limitation carbon monoxide test, and you can see how long it takes for that carbon monoxide to traverse the membrane. It's just to understand that it can cause both, because that's initially hypoxic, but in end stage, you get these kind of bully forming that do trap oxygen or trap gases as well, and then you don't remove your CO2 as well. Just wanted to go over a little bit of hypoxic pulmonary vasoconstriction. If you look at the lung on the right-hand side, that's an appropriate HPVC response of the lungs. This is what all of our lungs do. Let's say you've got an apical pneumonia causing complete kind of collapse of that apical zone. The lungs then, in the face of that hypoxia locally, cause vasoconstriction to that upper lobe and thus limit your shunt. But if you give too much oxygen, or let's say you're intubating someone in anesthesia and you're using sevoflurane or something like that, you can compromise that function and cause that vessel to dilate again. And then you're effectively worsening your shunt by pumping blood to a deoxygenated area of the lung, and you know that it's going to re-enter the circulation having not been oxygenated, whereas the right lung pushes that blood preferentially to the aerated zones of the lung. Just to understand that that's often why our patients deteriorate once you put them on high FiO2s. We were taught at med school that it's all about your kind of central drive, and I think that thinking is kind of falling away in terms of like your oxygen drive being from 60 millimeters of mercury PaO2 and being centrally driven in the chronic hypoxic state, a chronic hypercapnic state rather. But I think this is the new thinking in terms of why those patients deteriorate, and suddenly when you look at them again, their PaCO2 has gone up so highly. So options for ventilatory support in these patients, nasal prong oxygen is kind of our lowest support. Face mask oxygen, we've got the 40% Venturi, and we've got a poly mask. We've got non-invasive positive pressure ventilation. We can use a bag valve mask. We can use CPAP, and we can use BPAP or BiPAP. And then invasive can be supraglottic or infraglottic or definitive airways. Those are effectively our options, and deciding on who gets which option is, I think, the big stressor for the person in EC making this decision. So who gets NIV? Patients with moderate to severe respiratory distress with a respiratory acidosis pH of less than 7.32 is according to the basic guidelines. Somnolence, but maintaining the airway. So if they have had some sedation, they've got OSA or obesity hyperventilation syndrome, or they're just hypercapnic, but they're safely maintaining their airway, then you may consider it. And that's usually at a PaCO2 of more than 8, even though hypercapnia is more than 6.7. And then patients who don't have any concern regarding the safety of this in terms of facial injuries, recent surgery, beard, no teeth, those sort of things. If you're ever concerned and you feel like you need to secure the airway more securely, then consider airway, a definitive airway.
I might just mention about, in terms of titrating, because we see a lot of patients come in with, and then they type 2 respiratory failure. And it's probably that, and not criticizing this, but they give them a lot of oxygen, or someone looks bad and you give them oxygen. So if you start nebulizing someone, there's no way to titrate the oxygen. So really the only thing that you can titrate, apart from when you've got, doing non-invasive or invasive, is nasal prongs. You can't titrate to 40, and then not only be the mask, you also can't titrate. You're fooling yourself by doing 8 or 10 or 15. It's not supposed to work that way. So what we do is maybe for people in the ward, maybe just have an idea is literally that, and the Royal College of respiratory guy in the UK, so their guideline is at NICE also, is 88 to 92%. You don't want the sats above that. And the problem is if you're giving them nets, you've got nowhere to control it. So what we will do in EC is we will put nasoprongs on and titrate the sats and then net with air.
Yeah.
Because there's air. Now, not everyone has the luxury, but just keep that in mind when you're a patient in the ward, post-op or, someone's probably with a hip and whatever. Just pay attention to that O2 because it's a real pain once a patient goes to type 2 respiratory failure. And it's because of the oxygen that happens.
Yeah. So then who gets a tube is then the decision that needs to be made. And I think the overriding thought in our minds as MOs at George is this person a candidate for ICU? Before we even think, are they indicated, is the tube indicated, is we expect this may eventually become indicated. Are we going to do that or not? And often that comes down to a discussion with a senior colleague who has a bit more experience, who checking how many beds are available in ICU, the patient's HIV status, if they're well controlled or not well controlled on their therapy. Even some things as severe as like, have they previously defaulted treatment and proved themselves kind of unreliable patients? Who do we give the chance given our limited resources? But the patients who do get tubed, severe respiratory distress off the bat, low GCSs not maintaining their airway, either having excessive secretions or vomiting as well. And then any concerns regarding the safety of non-invasive ventilation. So if there's anatomy problems of the face or the airway, patients that you think you're going to struggle if they get further down the line, rather plan for a good initial airway maintenance protocol. Patients who are experiencing apnea, and whether that's like from a central cause or a peripheral cause, a biochemical cause, something that could probably be resolved through management. And then if patient is failing non-invasive ventilation, as I said, consider your ICD candidacy in our setting. So this is from Up to Date, and it's actually an anesthetic guideline. I just pulled what I thought was relevant to us from that, but consider these patients, they often get, and I think we found it more useful than not useful to give these patients a little bit of morphine syrup. It just really allows them to feel a little bit better. It suppresses the hypoxic response, and they just feel a little bit better and able to breathe more reliably and actually help them blow off some of the CO2. But avoid over-sedation if possible. Position these patients head up 30 to 45 degrees, so a little bit more than usual, because this helps maintain the FRC a little bit better. So especially if the patient's overweight, as a lot of our patients are, to try and get that abdomen off the diaphragm and really allow the chest to expand as much as you can. Because if you maintain an FRC, then you can pre-oxygenate well, and you can fill those alveoli with oxygen so that there's an improved tolerance for prolonged apnea in case you need to intubate the person. But this is only something you should be doing when you aiming to intubate, because then you can take control of the ventilatory side of things once you've tubed the person. Prevention of bronchospasm, I think this is mostly in a theatre context. We don't really do it outside of theatre, and I don't think there's strong evidence for it, but it's just something that was noted, and I thought it was interesting maybe to discuss with you and see what your opinion is on it. Not really good question. Yeah. Just thought it was just an interesting.
I think it's more for laryngospasm and the lidocaine is used for the intubation response. To blunt that response. I'm not sure it's great for bronchospasm. Well, the evidence for that is also not great, so that's why we never use it. And it's another fiddle when you're doing intubation and so forth. So I think they need to say, but I think they give what they give.
They give in theatre, but it's obviously in a controlled environment, so
they like it,
so just something to consider. And then induction agents. So obviously this is first world data here, but propofol, ketamine, short-acting opioids, and then they do suggest like dexmedetomidine as an adjunct. Obviously thinking about this from an anesthetic perspective, just that it decreases the cumulative doses of your other drugs if you're worried about suppression in that regard. I think if you've got a hemodynamically stable patient, propofol, got a hemodynamically unstable patient with some bronchospasm, ketamine is a great option. Yeah, so it'll be made on a patient case-by-case basis. And then the lung-safe strategy is an important part of ventilation for these patients, because if you've got such high resistance and such low compliance in these restrictive patients, you've got a massive risk of barotrauma. And you just need to consider your approach in these patients. So we take a low volume approach, start with a tidal volume of 6 mL per kg, and then you can titrate up at a later stage. Looking at your inspiratory-expiratory ratio, starting 1 to 1 to 1 to 2, adjusting to your PaCO2. I'll go through some specifics about this now. Adjusting your FiO2 to a target saturation, your respiratory rate to a pH and an EtCO2, and then PEEP starting at 5 and then cautiously increasing. We'll go through some issues just now about all of these things, but I think that's a good starting point for these patients, and then you can adjust to see how they can improve with each step. So, yeah. So I think the big thing that comes down in these discussions, and it's always a hot topic, is volume control versus pressure control. It really, I think a lot of the time comes to what you're most comfortable with as the person managing the airway. If you've got a pressure control scenario, then yes, you can limit the pressure, but you might not have, you might not get your tidal volumes that you're wanting to get in. If you start with a volume control mode, you'll probably get that volume and may have risk of causing a pneumothorax. I think if this patient is a good ICU candidate, you can really consider, trying to get your tidal volume slowly, and if the pneumo happens, put the drain.
But are you referring to pressure control versus volume control? You're talking about the pressure ventilation versus assisted ventilation.
Yeah, no, so pressure control versus volume control, especially when a patient with a restrictive.
So I think personally, when it's a difficult ventilation, I like to go to volume, because then at least I know the volumes are where I want them to be. Versus restrictive, a pressure one, you not keep, the volumes change the whole time. So if the patient does develop bronchospasm, then all of a sudden your volumes are down again. So when it's difficult ventilation, I prefer volume, but there's no real good evidence that the one's better than the other one. I think that's the bottom line. And we will use, in COVID, we used volume control a lot. It's just because it was easier, because you could keep an eye on the tidal volumes. We were really worried about the tidal volumes, but I wouldn't worry too much about which one you use. But I prefer it when I really want to have a good look at, keep an eye on the volume. But volume probably is important in this patient, because that is what's going to cause, if you over-distend the lungs, this is where the problem comes in, especially when you've got areas of atelectasis. And this is where I know you're touching on that, Johnathan, where we talk about the baby lung concept. So say you lose on the one side, you've got 50% less of your lung volume because of atelectasis or pneumonia or whatever. But now you're still sitting with 6 mL of tidal volume. So you might be over-distending other areas of the lung and causing barotrauma. And that's why we always aim for a lower type of tidal volume. But it gets difficult when you 6 and you go below 6 mL per kilogram. It's really, really difficult to get your CO2 controlled. And this is why I think it's a good start, but from there you're going to have to watch the patient.
Yeah, I think what is just highlighted is it's moving recently. Initially they thought that this was everything is uniform within the lungs. So bronchospasm, atelectasis, everything happens, but it's not. It's a regional phenomenon. So if you move your patient, that's why we prone the COVID patients. Everything changes with its anatomy. Upper lobes are usually better aerated and lower lobes better perfused. Those sort of things change a lot in the lungs. So some concepts here from the basic course, which I think are the most useful. is that oxygenation and alveolar ventilation are two completely separate things in ventilating these patients, and you can adjust each of them independently, which is quite nice. And it's quite nice to understand that. So how do you increase oxygenation? You increase your FiO2, and you increase your mean airway pressure. And you can do that in a few ways. You can either increase your PEEP or your inspiratory time, and I'll just go through a little diagram just now. It just helps me to think better when there's colors and flow involved. So this is what I drew up. Thank you. So how to improve oxygenation? So your goal is to increase an arterial PO2. You either increase your FO2 or you increase your mean airway pressure, or you mean alveolar pressure, sorry. And that can be done in two ways: increasing your inspiratory time through the IE ratio or adding an inspiratory pause. And those are just some things you need to consider. That will have an impact on your ventilation side of things if you do change that, but just keep that in mind. And then you can increase your PEEP as another method of increasing your mean alveolar pressure. And that's why in ICU, they've got the PEEP tables. So as soon as your FiO2 goes up beyond a certain thing, then it's advised that you increase PEEP to a certain level, until you're trying to gain that oxygenation that you need. Obviously, considering that beyond a PEEP of 10, you really have a higher risk of hypotension in a patient with a normal functioning heart. So it's a balance between the intrathoracic pressure and the transmural pressure of the heart. So if you're increasing your PEEP so high, you're going to struggle to create that negative intrathoracic pressure, or when you positively pressure ventilate against that. And that causes a reduced venous return to the right side of the heart, which can cause hypotension through kind of impeding Starling's force. Whereas if you have a person, let's say they've got a heart failure on the other side of things, causing an increased intrathoracic pressure might stabilize the transmural pressure and allow the heart to pump a little bit better. So just considering that balance in your patient is important. And then how do you improve ventilation side of things to decrease your PaCO2? So the two kind of really that we're able to monitor and move very easily is your tidal volume and your respiratory rate. So together those will effectively make your minute ventilation. And then to decrease dead space in your circuit so if you've got a lot of these extended little thingies to try and make it more comfortable, if you're struggling with CO2, kind of shortening that little concertina help. Getting a shorter loop might help. Unfortunately, it's not something we really fiddle with too much, but conceptually, just understanding that is important. Yeah, so just going on to some adverse effects. This is like near the end now, but barotrauma is important to understand. Consequence of high maximum alveolar pressures, high tidal volumes, and then shear injury. So these alveoli that fall flat on themselves every time you breathe. So you breathe out and they collapse, and then you open them again and you pop open, and they fall flat and they pop open. And that shear injury can cause pneumothoraces, and even if it doesn't cause a pneumothorax, it still causes damage and inflammation at the alveolar level, which can worsen your ARDS. Gas trapping, less likely in normal restrictive lung diseases than obstructive lung diseases. Obstructive is obviously the big one, is the gas trapping phenomenon that you're trying to actually fight against. And I think the archetypal ventilation there is for the asthmatic, where you're really trying to allow this person extended expiratory times with positive pressure to try and allow those at the bronchial level, or almost the bronchiolar level, to stay open, to allow the alveoli to collapse and get that air out in the context of a massive bronchospasm. Yeah, oxygen is just something we always need to think about. I think we often find, like, I'll put a patient on ventilation, do a gas, and then come back 6 hours later and the PaO2 is like 15. Jeepers creepers, because oxygen is toxic to the lungs and to everywhere else. So just be aware of that. And then the cardiovascular risk effects, which we discussed already. And then understanding that every time you put a tube in someone's throat, infection is an option, and nosocomial infections in someone who's already so sick that they need ventilation is just an issue that we need to be aware of. Yeah, so that's effectively where we're done. I've just got a little bibliography just to say where I got all this information from.
Ninja nerd.
Hmm?
Ninja nerd.
Ninja nerd.
Lung disease.
Ninja nerd.